Health insurance? Well, we'll tell you what you have to do to be ready in this edition of the Reid Factor. My special guests today are Dr. Delon Brennan, who is the project manager for National Health Insurance, and Deborah Bastian, who is a consultant to the National Health Insurance Implementation Team. Welcome to the Reid Factor. Now, let's start off from the basics. First, what is National Health Insurance, and how does it differ from the services that are offered right now?
Sure. National Health Insurance for us is really a launching pad into what is considered universal health coverage, and it's really ensuring access for our entire population to health services in an equitable manner so that they don't have to worry about not having or having money at the point of access to care. They'll be able to access services at the time they need them without the limitation on financing.
Who will be eligible?
So essentially what we want is all citizens and legal residents of the Bahamas to be eligible for participation in the service. It does require that you have to be normally resident in the populace or in the Bahamas, in the country itself, in order to participate. But we want as many people as possible to be able to benefit so that we can all see how NHI can benefit all of the people who are here at the time.
Right. Now, from my understanding, right, unless you have this card, right, this national insurance card, there's no way you're going to be eligible or able to access any of those services. Is that correct?
That is absolutely correct. So what we have done is really partnered with the National Insurance Board and allowed the introduction of national health insurance really to be springboarded by using the database of eligible participants through NIB to then allow us to have an eligible population to start our enrollment with NHI. So what we do know is people will need to have their new NIB smart card and be registered with NIB so that when we do the enrollment for NHI, likely to come within this first quarter of 2016, we'll also then be able to have that information already available to us, and people will then be able to make the choices that are necessary for full enrollment into national health insurance.
Now, what are you finding so far in your involvement in the NHI team, Deborah Bastian, about the whole process?
Well, the process right now is really going very smoothly. I'm working basically on the financing aspect of the NHI, and in terms of that, we're looking to see what NHI is going to cost. What is going to be the total cost of NHI? What if and when there are contributions that have to be made by the populace, what is that contribution going to be? What is for example, if there are contributions to be made, what is the employer going to have to contribute versus what the employee is going to have to contribute? So we're looking at having NHI not only introduced, but having NHI be sustainable financially. And how do we sustain NHI not only at the beginning, but for many years to come?
We know that Saint Just International has been involved greatly in this, but there have been comparative studies, I'm presuming, with NHI, like in places like the UK and Canada. And how will ours be similar or different to what they offer?
I think ours is really, as much as possible, a pulling out of the best pieces of each of those systems and trying to adapt into our Bahamian context and our Bahamian realities what our program needs to be. We do know that ideally, we have a system that is composed of including all people. We have other systems out there that only choose some portions of the population. You either have to be low income or you live in a particular area in order to access it. We know systems that really address the entire population work best. We also know that from learning from other systems that starting with a base of primary care is the best way to address the population's health needs right from the beginning. So especially addressing the preventative aspects of care, making sure that people have access to education and services that will really benefit them before they become ill or early in the course of disease.
And I think that's what a lot of people don't get. They figure that it's just for the right now, but you're looking at ensuring the overall health of the Bahamian public for years to come, so that if they're getting what they need at the primary level, when they become 25, 30, 45, 50, they won't have to be such a burden, if you will, on the system.
No, absolutely. And for us, it's really a growing part of the process as well. We've seen the growth in our systems, or in systems around the world. We've also seen the growth that has happened in our system, and we really want to revert to a system whereby we're addressing those primary needs early. We're also able to ensure that we're keeping people healthy, because right now, yes, we have very advanced levels of care that are available in the country, but we're not able to have everyone access them. Is everyone accessing those primary basic services? We're not doing that. So what happens is we end up with higher levels of disease and higher cost illnesses down the road. And we know from systems that have really addressed that, they've been able to keep, or at least monitor, and while suppressing the rise in healthcare costs, while getting the people healthier at the same time. So we can do that in our system by modeling after some of those other parts.
Great. And we're looking at what healthcare costs in the country generally now, obviously, as part of your investigations, right?
Yes, and we all know that it is far less inexpensive to provide primary care as opposed to having to provide later down the road catastrophic care. And so therefore that's why we determined that you should start with primary care as the services that will be provided as opposed to catastrophic care. But there is provisions for catastrophic care. Even though we're rolling out with primary care, we will make provisions for
and I'm glad you said
care.
that, because there's a sort of little talk out there that it won't cover catastrophic illnesses, but that's absolutely incorrect.
For us, we definitely know that we want to make sure that first we take care of people's primary health care needs, but in addition, you are going to discover levels of illness that were previously unaddressed for people who just didn't go into primary care or weren't getting, their health maintenance visits as they should have. You'll have them get into a regular system of care, and you'll discover that there are people who already have illness, and you've not prevented that. You've just discovered it now that you have better screening and people are actually being seen. But this will allow us, once we discover what those illnesses are, we'll be able to enter them into the system. And like Ms. Bastien said, there will be funding that will be available, but that system will be based on having protocols to decide who is it that needs to have that level of care. What are the health parameters that you need to achieve in order to get there, so that it doesn't become arbitrary as it is sometimes now, based on how much money you have, who you know in the system, where you live. Do you live in one of the family islands? Do you live in New Providence? We want to make sure that there is a very systematic way that you could just read it for yourself and tell, am I someone who is eligible for that higher level care? Or is this something that can wait and we can address this at a later time? But we do need to have funding to address some of those issues.
Without getting into the full details of the contributions right now, because I know that that's something that's being looked at much more seriously right now, but tell me, do you guess that as time goes on, whatever the contributions are, that they might be less over, like, say, a 20-year period or so, as the system really develops?
Well, I think it's important to note right now, and where we are, is that the NHI, as we anticipate that it will be, and as the services are rolled out, that we cannot sustain NHI without having contributions made.
Absolutely.
That's critical. I think that's an important point to point out. I think, though, you will find with the contributions that are going to be made, I think that we must remember too that the reason why we will have contributions as well is that we have those that are able to afford will have to somehow assist in the benefits of those that are not able to afford. And that's just the way NHI systems are. And so I think that initially, when we start out, we will start out with an amount that is easier on the population, because persons are saying that we just introduced value-added tax, and so what is this going to cost me? Employers want to know what it's going to cost them. Employees want to know what it's going to cost them. And I think we have not worked out the full costing of what that will be as yet.
Now, there's obviously, from particularly what you pointed out too, there is a socialism aspect. Well, it is really, right? And I want you to explain from a medical practitioner's point of view why it is so important for us to actually have that kind of attitude, if you will. How we could be negatively impacted if we don't take care of those who really can't afford it.
I think one of the things, this is one of the unfortunate seeds that we are seeing manifest itself right now, is that our lack of action in this particular arena 20, 30 years ago is manifesting with the levels of disease that we have right now. So those people who are not able to afford to access care or didn't have the access to care because they were located outside of the regular health system, they now are manifesting disease states that we still have to pay for. And what you find out is they weren't able to pay for lower level care at the time, and now that they're entered into the system needing secondary or tertiary level care, so they need hospitalization, they may need surgeries, they may, advanced procedures, because they didn't have the money to care for it before, nationally, we still have to, through our normal taxation methods, through the public sector, pay for that care to be delivered. So it's a smarter idea to develop an entire system that says, if I'm able to make sure that people can access systems within the health system as a whole, again, not just in the public sector, but in the public and the private sector, you're able to provide them the services that they need, especially on the prevention level, then you'll find out that later on, the public purse isn't taxed at that same level because people don't require as many of the high-level services. They're actually able to have their needs addressed earlier, and then they are able to continue to be productive members of society for a longer period of time because they don't have the same levels of illness. So you have people with less days out sick, you have less people who are needing to access services outside of the country. All of this allows for more and more national development because people are on the job, but at the same time, they're even able to participate in the health sector, from a community standpoint in keeping themselves and everyone else around them well as well.
Great. Well, we're at the end of, you have some,
You know that there's a saying that says that prevention is better than cure.
Absolutely. Yeah. Well, we're at the end of our first segment, believe it or not, and we will be back with Deborah Bastien and Dr. DeLon Brennan. We're talking about national health insurance. Get ready so you can be enrolled. Stay with us. Good. Welcome back. We're talking with Dr. DeLon Brennan and also with Deborah Bastien. We're talking about national health insurance. You have to have your national insurance card if you're going to be able to access the services of it. Enrollment is now in the process of being done. We're talking about the sustainability of it, right? And that's why the contributions are necessary, right? You also said that even though that's being finalized right now, the exact amounts that people are going to pay, that it will be affordable.
Yes.
Yeah. For the person who is a domestic, let's say, who has 4 or 5 kids, how does that work out? How do you think that's going to work out?
Well, the one thing that we know that we're moving, the system has to be both public and private sectors, because when we talk about health care in the country, we must make sure that we are not making the distinction between public and private. There is only one healthcare system. And so we're trying to make that healthcare system, the healthcare system of the Bahamas, modern, affordable, and accessible to all, including the housekeepers.
Obviously, children, well, for the most part, do not work. So that primary care, though, is free. No cost at all necessary for that. Obviously, because they can't work to make contributions.
Right.
No,
but it's not just free for children or the indigent or senior citizens, as for the most part it is right now. It really becomes that we want to introduce primary care without those cost barriers, so there are no contributions to it. But you also, unlike what people have right now, let's say one of us needed to access the system, we would be charged a registration fee if we were in the public sector, or if you were in the private sector, if you had private health insurance, let's say, you would have either a copay or deductible to pay. National health insurance essentially eliminates all of that.
Which is a good thing, because often you go to the doctor and like in some cases maybe a $500 deductible.
You could.
And what you need to have done
is much less than that.
Much less than that, but
Right.
you still don't want to have to pay.
But you still have to pay for that as well. And I think that's one of the big things for us, because as we roll out national health insurance, we really want people to start to feel the benefits that come along with NHI before any thought of having to pay for that comes along. We do know that any government revenue or any government program comes through general revenues anyway. So we all pay anyway for this, but this is a new system of using those things that we already have, the payments and the contributions that we already have within the system. So there's nothing new for us to pay, but we need to start to feel how NHI changes the health system, our access, our ability to really get the services that we need before any new thought of contributions come into play.
How do you see the method how do you foresee the method of payment coming out? How do you see that happening?
Once the contributions are introduced, we see that those contributions will be made through the system that we currently have, which is the National Insurance Board.
So it'll be done in the same kind of way.
Yes, so National Insurance will actually continue to collect those funds on behalf of the National Health Insurance.
So that's done before you get your pay.
Yes,
at the
so
end of the
that
day.
yes, so those and that's the reason too why the National Health Insurance card is vital as well, because when we move to contributions.
How will because they have the prescription drug plan right now for seniors. How does that fit into this, and will that be affected at all by what's happening?
Absolutely. What you'll see is that there'll be an amalgamation over the years of what is now seen as the prescription drug plan into national health insurance.
Great.
So when we first start, what you'll notice is that those pharmaceuticals or drugs that are currently covered under the drug plan that are related to primary care, those will be rolled into NHI. So you won't need to use your prescription drug plan card to access those medications once you are enrolled with NHI. Going forward, we do know that not all of the drugs under the prescription drug plan are primary care drugs. So at the initial registration, there'll still be some drugs there that won't be accessible through NHI. You'll still use your prescription drug plan card for that. But as we progress, and we get into some of the more secondary and tertiary care services, what you'll notice is all of the drugs under the drug plan will then be rolled into NHI, and they still don't represent all of the medications or pharmaceuticals that are included in NHI. That will still only be a subset, because those specifically address chronic diseases, but all the things under acute diseases, all of those will be included in NHI, but you won't necessarily need two cards to do it. You'll have all of those benefits under national health insurance.
So at the end of the day, it'll just be much more efficient.
It'll be much more efficient, yes.
Tell me this now, and this is a man's question, because we know men don't go to the doctor.
No.
Is
As a rule, we don't do very well.
this is designed to try and encourage men to get their annual physicals or whatever?
You are correct. So one of the things that we're doing with this is actually improving responsibility, not just on behalf of the patient, which right now, all the responsibility for accessing care is really on the patient. If you decide you're going to go to the doctor, you go. If you decide you're not going to go, there's no penalty or anything for that. What we really want is change the responsibility, not just to the patient, but the entire system has a responsibility to make sure that you stay healthy. So then we start incentivizing providers to make sure that you stay healthy as well. So providers are paid essentially to ensure that you come and get your physicals, that you get the necessary labs and screenings that you need to get done.
So that means, sorry, I'm sorry to interrupt you, but how is that going to be too? Is it going to be like it is in the UK, where if you live in the southern portion of New Providence, that you have to go to a provider that's in that area? Is it going to be specific like that, or could you go to any person who's registered as a practitioner under the National Health Insurance Scheme?
I think the good thing about having this type of program in place in our country, specific to us, is that we have fairly small geographic areas on our islands. It's not like the UK where you have a huge geographic area, and so the limitation of services is necessary geographically, because it would be very difficult to get someone to another area if they signed up with it. But in New Providence, you could live in the eastern area of New Providence, and to get to the west still only takes you 20-30 minutes. So if you chose a provider on the western side of New Providence, that would be okay, because we don't need to geographically limit people. Now, you may choose to stay with a provider on your side, but this is the big thing about national health insurance here, and one of the big issues that we have tried to build into every part of NHI is giving you as the patient the choice. So this allows you to choose who you would like to have, and that allows them, geographically limited to islands ideally.
So that gives them greater options than they would have had ordinarily,
Absolutely.
I think.
Absolutely it does, because even in some of the private health insurance networks at present does include every doctor and every facility, within the Commonwealth. We're opening this up such that if a provider is able to qualify themselves and then certify as a provider under NHI, essentially almost any patient could decide they want to sign up with them. And that freedom of choice is something that we use every day in building our design process around national health insurance.
As far as registration, and I see that they're now heightening registration enrollment. They're heightening the process right now. We had a report here on ZNS on the weekend that showed how you had more people to actually help and go out. They're going to be situated in different centers. In other words, so you don't have to actually go to the National Insurance Board's headquarters to get ready for this. Is that correct?
That's correct.
Where can you go?
Actually, National Insurance will have mobile centers as well. I think with one of the intentions is that they would go to the larger employers and register persons that way as well. But they will have centers in the north, the east, the west, and the south. And they will actually say where those centers are. The times also will be extended. So it will be beyond the 5 p.m. It will probably be until 9 p.m. But they will make those announcements very shortly as to where those centers are, including when the mobiles will be available.
Are you looking at ways that you can sort of stop people from defrauding the system? Because we know that, with national insurance itself, a lot of people try to, get a leg over. What steps are you looking at, or the implementation team looking at, to sort of prevent that from happening?
Well, I think initially with the implementation, we're trying to make sure that all persons that are entitled to be registered under NHI are registered. I think for us, that's our key there, is to make sure that only those persons that are legally entitled to be registered under NHI are registered.
But is there a possibility that once you do fit that criteria that you could still defraud it?
I think fraud is available in many different ways, and I think as we move through, we'll continue to use best practices to ensure that that is minimized. But I think the principles of NHI, for the most part, help to dictate how we continue with design along the way. So universality implies that all legal residents and citizens become involved in the system. So essentially getting everyone involved is the best way to go. We want to make sure that payments are going to providers to take care of patients. It's not just waiting necessarily until a patient comes in. We want to make sure that providers are paid to really get their catchment population in and get them the services that they need. And as they get their patients healthier and healthier, they actually, we're building into the system so that as we evolve, they'll actually be paid for the health of that population. As they get better, they get their screenings done, they'll actually have that happen as well. So everything is subject to, some sort of inconsistencies that can happen. But I think with this type of system where you build in management structures and you build in a better governance to the system,
It limits it.
you limit that as much as you can.
You have to make sure that you have checks and balances.
Yeah,
And that's what we're ensuring right up front, that we have checks and balances.
What do you see as the biggest challenge from your perspective in this initial phase, let's call it?
I think the major challenge for us would be, I guess, getting it right with the providers, ensuring that the capitation rate, that we're actually going to negotiate those and get that right, is the major challenge for us at this point, just to make sure that
We know
have
that the insurance agencies and the government are still negotiating as to how they're going to come to terms with what they have to. But, and I'm only talking to you about from someone I know was thinking that the minute you got this, you'd have to let go of your private insurance policy, that you couldn't go to a private insurer anymore. Dispel that for me, please.
Oh, no, that's certainly not so.
Yeah.
We're saying that
You have a choice.
you have a choice. You are going to be able to get supplemental insurance from your private health insurers. Remember now that when we roll out, we're rolling out initially with primary care, and so we're not saying that you can only get primary care and you can only get it through what NHI is offering. No, that's not it at all. You will still be able to keep your private health insurance, but you will be able to keep that if that is what you desire.
But you will still get the same services through NHI.
Through NHI.
We're at the end of our second segment, and regrettably, we're going to have to say goodbye to you. It's very good to see you, and
thank you.
Best efforts, best wishes as you continue to carry this out. And after the break, we're going to keep Dr. Brennan, but we're going to have another guest right after this. Stay with us on the Reid Factor. Welcome back to the Reid Factor. We're talking about national health insurance. Of course, you need to get your national insurance card if you want to access the services. But our guest, Dr. DeLon Brennan, and now joining us is Damara Dillette, who is a legal consultant to the NHI implementation team.
Yes.
Welcome.
Thank you for having me.
Good. We know that we were talking during the break, the legislation that was done, but of course there is new legislation that's coming up.
Yes.
But what is the legal basis for what you're working with right now on NHI, and what are the challenges you're facing?
All right, so the National Health Insurance Initiative, or the plan, it stems from the government's initiative to try and get implemented or some access basically to universal health coverage, universal health care. And this particularly global initiative comes from some of the efforts of the World Health Organization, WHO, or the Pan American Health Organization, also known as PAHO. And so we've used that as our benchmark or international basis to ensure that we're able to provide to the Bahamian citizens affordable, accessible health care that's modern, it's patient-centered, and it allows everybody to access the needs that they
We should point
require.
out, right, that this is one of the UN Sustainable Goals,
Yes.
right, going
Yes.
post-2015.
It is.
Right.
It is. And so in doing that, we've taken a look at all of those international standards and tried to provide legislative framework that truly reflects those initiatives. And so we currently had on our books the 2007 National Health Insurance Act. That act would have been passed, but it was never brought into force, and so never given effect, really. And so we've looked at what presently existed or exists, and we've looked to see whether or not what is truly intended is exhibited in that particular piece of legislation. And we came to the conclusion that so many changes needed to be made that it may be best for us to just repeal that piece of legislation. And so we went through a whole series of meetings and negotiations, etc., to see what framework would better suit the intentions of the National Health Insurance Plan, and came to the conclusion that it may be best to draft a new piece of legislation. And so we've been hard at work drafting that new piece of legislation.
You have been directly involved in the drafting of this?
I have been directly involved
Great,
in
so
the
you
drafting.
actually know what's coming up then.
Yes.
Changing a little bit, infrastructure is one of the issues that is critical to this, right? We've been seeing some beefing up of infrastructure as we go along. But I think one of the things that I see from this now, we know that often, and I believe that we don't have to go as often as we do now, but BAME's like to travel abroad depending on what it is. But I think because from what I'm hearing from you, the standard will be so much higher that there will be even less need to consider that as an option. Am I correct?
I think so, but I think what we also need to know is that we have so much infrastructure already available in country to us that what National Health Insurance is really allowing us to do is expand the access to even those systems as well. Even if we just consider the primary care rollout that starts in the second quarter of 2016, in expanding people's access to both the public sector and now the private sector through this public financing mechanism, you've now at least doubled your offerings from what you had before. So if you were only able to access the public sector using public funds before, now at a minimum you can do the public sector and the private sector locally. And that means that all of those private sector clinicians who before weren't necessarily able to access the entire 100% of the population because people couldn't afford to come to them. They couldn't pay out of pocket or they didn't have private health insurance. You've now provided them with a captive audience of people who can now access those services as well. You'll feel it even more so the more services we're able to add and roll out. So when you talk about specialist services, especially those that aren't necessarily available in the public sector, when we get to offering specialist level services and then tertiary level services, you will then actually be able to access those services as well through the same funding pool in National Health Insurance, both again in the public sector and the private sector. And being able to do that means that there will be less of a need for people to access services outside of the country, needing to go whether to the north or the south of us in order to do that, because we have great services that are available here. We have many, and it's not limited to physician care, but you have physicians, nurses, allied health professionals that right now are able to offer great services to people, but unfortunately because they weren't able to access the entire populace, their services weren't truly accessible.
Now, I believe in the initial, and I think I cut you short. I'm sorry when you were talking about it. You can bring those points up now, though. But when you're looking at the legislation, I believe it was in the original act. I can't remember now. But what about malpractice issues? How is that going to be addressed within the legal framework?
So, with respect to the legislative framework that we're currently working on, we're in consultation with some of the doctors, looking at some of those consequential issues, some of those ad hoc issues, trying to see how best with this implementation and rollout of NHI, we're able to address some of those concerns. Now, we do realize and appreciate that there are a plethora of issues and concerns, particularly those that have been voiced by individuals in the medical profession, that may not necessarily be achieved solely through the implementation of a new NHI Act, but through our exercises, we're looking at all of the legislation that touches and concerns healthcare, whether it be facilities, administering of services, to try and see how best we can work collaboratively along with the Ministry of Health and other organizations to bring about that necessary change.
Well, rehab centers be part of this whole system, take it into consideration of this whole system?
So
post-op rehab centers.
Right, so given that particular thing, I think it's one of the instances it gives us an opportunity to really clarify what we're doing in rollout and what the stages really imply. So we have registration that happens at the very beginning, and then we roll out when it comes to care services with primary care first. Primary care services as a whole really speaks to that first level outpatient, essential level of services that people get. If you think about it sort of in layman's terms, you think about, what do I go to the clinic to get services for? Now that clinic may be on an outpatient basis, your general practitioner, your family medicine specialist, the pediatrician, the internist, even prenatal services that you get from an OBGYN. Those are the types of services we're talking about. The things that they may prescribe medications for on an outpatient basis. So it doesn't require a specialist, it doesn't require hospitalization. What are those medications that they would prescribe? Those are included as well. What are the type of screening services? So let's say mammograms or prostate, or if you needed to have your hemoglobin A1C checked because you have diabetes and you need to do it every 3 months or every 4 months in order to ensure that you're paying attention to your sugars, and if it gets too high, then your doctor can change your regimen, which people aren't doing as much right now, and that's why we have such a high rate of diabetes, is we need to get people involved, but we need to have those care services delivered outpatient in your community where you can access them, so that from the very beginning we can prevent you from needing the higher level secondary and tertiary care services. Secondary care is really when you need outpatient services, but they're done by a specialist, like let's say, for example, a cardiologist or a nephrologist. Those are secondary level services, but still on an outpatient basis. If you need to be admitted to the hospital to have something that can only be done in a hospital, those are essentially tertiary level care services. So again, we're only starting with primary care right now.
Right.
So those are the services will be included. It's not to say that we won't have secondary, tertiary, and then rehab type services afterward, but right now we're focusing on how can we prevent people from ever needing to go to those services. Then as we roll forward and we roll into the instances where we have a better idea on the cost for those things, and we know what are the utilization levels in country, once you put primary care in place that is needed for that, then at the same time we'll be able to say, okay, we know how much money we're going to need for those services, we know whether contributions are going to be needed or other sort of financing mechanisms in order to get us there, then we'll be able to roll those things out as well.
Now, with regard to the family islands, in order for them to have the primary care, it's going to be, and we were told that there would be a doctor on every island or every main family island. Have we achieved that?
We're actually getting there right now. There are very few family islands, save 1 or 2 at present, that doesn't have a full-time physician on their island. But that doesn't mean everyone can access it, because unfortunately we have some islands that are geographically very far apart. So it isn't just being able to stick a pin or a feather in our cap and say we have one physician on every island. We need geographically to make sure that it's a proper distribution for people to be able to access those services. But a lot of times, services aren't just accessed by, I have a physician on my island, so now I have access to services. We have to use even modern technology for us to be able to get services delivered as well. So when you think about telemedicine or telehealth services,
and we've been using that for some time, right?
We have used it. We've had really good pilot projects to get it done. But with the introduction of national health insurance, what you'll see is being able to provide better access to care now becomes a mantra for us. And in doing so, we use those types of services even more so. So it isn't just saying you have to have the $50,000, $100,000 piece of equipment available. We'll be able to use other types of technology, telephone, things, proprietary things like Skype, or, those types of ways to do it in order to get either primary care or specialist level care services to you without requiring that you need to travel for it. But if you have a large enough population that needs a service, and it makes more sense for us to bring in a specialist, even for a visit once a month, 2 times a month, then we can do that as well, because that means flying that one person to you and your community is cheaper than each of you having to travel to the specialist to get that done as well. But I think it's opening up the market for even those who aren't in the public sector system, but the private sector says, I think I have a unique way to develop my service to be able to deliver it. NHI says, okay, well, we see how that can definitely work. Let's compensate you for delivering care services in that unique and modern and now accessible way to the populace.
Which brings us to the issue of doctors and who actually will be involved, because not all doctors have to be part of it, right?
No, absolutely
it's a
not.
Voluntary.
It truly is a choice. But what we've heard over and over, and from our medical colleagues, is that they see this as a benefit, and no one has come out and said we don't see where universal health coverage is a benefit to the populace, and they want to see, how can I get my services delivered to the Bahamian populace as well? Now, of course, no one wants to go broke in delivering those services, so we have to have fair compensation for them to deliver those services, but it is a little bit of a pull and a push to get us there, so that when we can agree on what fair compensation is for delivering a service, then they have access to the entire population of the Bahamas.
People who wouldn't have been able to afford their specialist care before.
Absolutely,
So
people could
you may
not
be
afford that
getting
before.
a lower rate, but you're getting more.
And you could. It's not to say that there's going to be a lower rate for everything. Some will be compensated at the same rate they are now. They just have access to a higher level, higher number of patients, and they may truly just see an increase in the number of people who can come to them, and thus an increase in their revenue. But it doesn't mean that everyone's going to see, everyone assumes, and I think this has happened across the board, especially in our neighbor to the north, that once you have a nationalized system in place of funding, that it brings down the price. That doesn't happen for every service. And you have introduction of new services that never even had a price before, so you get to feed into those services as well. So I think we have to look at it with an open lens to say, yes, there may be some where the price does come down, but you had to keep the price at that level before, because your compensation, you weren't able to see enough patients to keep the doors open unless you had a price point that was that high. But now that you're seeing 1.5, 2 times, 3 times the number of patients, you can bring your overall pricing down because your per unit cost isn't that high. And so it really does balance itself out in the end, and I think we have the ability to watch the system develop.
Great. We got to take a break, and we'll be back with our final segment here on the Reid Factor. We're talking about national health insurance. Make sure that you're ready to access those services, at least in primary care, right away. We'll be in our final segment here, talking about national health insurance and the implementation of the primary care level of it. Dr. DeLon Brennan and Damara Dillett. And of course, you've been involved with all of the legal aspects of it. Give us an overview as to how those all of the legal aspects of it come together for the people of the Bahamas.
All right. So in terms of it coming together, we have a lead piece of legislation, which is intended to be the National Health Insurance Act. And that act sets out the basic legal framework. It sets out objectives of what national health insurance will be. And so it looks at the concepts of equity, making sure that across the board there's equality in terms of the provision of healthcare services, looking at trying to attain universal health coverage through the legislation and the implementation of the National Health Insurance Act. The act goes on and provides necessary details with respect to who's going to govern it, the authority, its powers, its functions, that sort of thing. Outside of the National Health Insurance Act, we know that there are other pieces of legislation that will be affected, and so we've had to take a very close look at the current Insurance Act, because the Insurance Commission at present is the regulatory agency that ensures that private insurance, particularly private health insurance, is properly governed, policies are akin with the functions and powers set out in the regulations set out in the Insurance Commission Act. So we've had to take a look at that piece of legislation and realize that the implementation of this new National Health Insurance Act is going to have an effect on the current Insurance Act. So we're looking at the regulations as it stands now to ensure that whatever amendments are necessary to give effect to the true essence and intention of national health insurance, those amendments are made. Additionally, we're also looking at the health pieces of legislation, Health Services Act, those sorts of things, the way that the current Ministry of Health functions, the way that the PHA, Public Hospital Authority, functions, the way that the Medical Council is set up, those sorts of things, just to make sure that everything flows in tandem.
So for people who really, because as you go through this is extremely complicated, obviously. So people who are thinking that it's going to happen just overnight.
No.
It can't.
It's not going to be something that we just wake up one morning and say, ta-da,
here's
your new enacted piece of legislation. We don't intend to do it that way. The government has made it very clear that stakeholder consultation is necessary. They would like for this draft piece of legislation to be taken to the public, for them to review it, read it, give their feedback, give their comments before they sign off and push it forward to Parliament. So you would have seen recently in the news that there was a draft piece that was taken to Cabinet. Cabinet looked at it, reviewed it, and basically said, it's okay in principle, but they've made it a proviso that we need all of the key stakeholder groups to take a look at this piece of legislation. We need the public to be made aware that this draft legislation exists, what it contains, its contents. And so right now we've started our process of engaging with our stakeholders. We've started with some of the healthcare providers first, and those consultations aren't completed as yet. It is intended that further consultations will be done. So we want to engage a broad sector of the doctors, both the senior doctors, the junior doctors. We want to engage with those allied health professionals, our nurses, physiotherapists, our lab techs, our pharmacies. We want to make sure that we extend and have really in-depth discussions with our private insurance industry. We're definitely working hand in hand with the current Insurance Commission, or the Insurance Commission. We want to ensure that the Chamber of Commerce is on board, that our labor, our unions, our teachers, that everybody, every key stakeholder and organization is approached. We sit and we take the time to go through the draft legislation with them, help them to understand what it contains, why we chose to draft it the way that we did, get their feedback, get their input, and be in a position to say to the government, these are some of the concerns that were brought to our attention. These are some of the recommendations we have with respect to these concerns. And then, of course, we want to make sure that that piece of legislation is made available to the public, to the average Joe Blow, to the fisherman, everybody in the Bahamian community.
So people that have so many concerns, in order to allay their concerns, is realize you got to understand that this is a process.
Yes.
It can't be bam like that from day one. So just relax and be prepared to access those. I mean, I hate to say it like that, but really that's what it is, isn't it? Young doctors coming into the country, this must present a great opportunity for them.
I think it's an excellent opportunity for young professionals in the medical field as a whole, not just doctors, but I think
That's true.
It actually opens up some of the areas of the health professions that we haven't even touched in
Like
the past.
research? More in research?
Research, absolutely. We talk about some of the allied health professionals. This allows us to truly have a financing mechanism where people don't have to worry about only the people who are rich or people who have access to health insurance can afford to pay for my services. I now have a service that I can offer to the entire population, and everyone has an opportunity to really take advantage of what it is I'm offering at the same time. And that allows you to think beyond what we see as the general structure of medicine and health that we have right now. I think, the new opportunities for educators, for advocates in the system, these are bigger parts of the health system where you can touch people from primary care where they have never done so before, and it's not just waiting for them to come into an office to have a service delivered.
You're talking about the establishment of new careers, new jobs.
Exactly, and I think that's the big thing. People have always, whether it's through the news or, the sort of general mill of talk, have all said there's going to be contraction in this service, there's going to be loss of jobs here. To us, this presents such a huge opportunity to open up the health field in traditional ways, but also non-traditional ways, where people are really able to say, how is it that I see I can impact the health system? Because there's a funding mechanism to get it to me. It isn't just I have to allow people who have disposable income or those who have health insurance that allows them to access the service. I now have an organized, transparent way to say I'm offering an evidence-based service that I can show you that this helps a portion of the population, and we can negotiate how this could be included so that we can improve the health indices that we currently see here in country.
A lot of what you're saying too is that people are always afraid of change.
Well,
isn't it?
that is true.
The thing is, typewriter sales people have no jobs no more,
Yes.
but laptop sales people
Exactly. It evolves. You are absolutely right.
Just kind of move with the times and come up to breast with the changes. I've always said, it's in making an omelet you have to break an egg. So, that's going to be a little breaking process, but at the end of the day, there's going to be a wonderful product that's for the Bahamian people that allows them to get affordable, accessible health care, and that's the focus and that's the drive. Yeah.
What else would you like to see moving forward, since we're on you right now, Ms. DeLay?
Well,
Having been so personally involved in it from the drafting level.
from the drafting level, one of the things that we've tried to ensure is that the legislation ensures that everything is patient-centered, kind of people-centered. We've heard even doctors and professionals say, a lot of times, decisions are made that seems to be more for the benefit of the medical profession or more for the benefit of the business person. But now we're trying to give it a whole new spin and say, okay, you know what, this is going to be something that's patient-centered. The patient is at the center of it all, and we're going to ensure that everything that the patient needs, or try to ensure that everything that the patient needs is built in legislatively, so that at the end of the day, they're able to access healthcare services the way that we feel that they ought to. And there should be no barriers, no restrictions. How much you make should not basically determine how much of the system you get to access. And so those are some of the things that we are focused on. What I would like to do is just encourage individuals, once we're able to push this draft legislation out for stakeholders to take a look at, for the public to take a look at, that everybody take the time to go through and read it. We've made sure that the language is friendly, so we don't have
that was going to be my main thing about you.
The hell-wits and the hithertos.
If it's full of legalese.
We've tried, mind you, there are some phrases that you can't run away from, but where we could change it, we've made it very plain and simple language so that anybody can just pick it up and have a good read of it. And yeah.
Are there time frames in it, strict or flexible time frames for implementation of certain things? As we know, we're in the first phase, primary care phase now.
Yes.
Are there?
In the Substantive
targets,
Act, we do not have at this time built-in hard and fast deadlines. What we've tried to do is allow for it to remain a bit flexible, because we can't anticipate what the public is going to say, what the stakeholders are going to say. They may come back to us and say, listen, we just think that this is, something that needs to be reconsidered, and if that is the case, then the government needs to be in a position to go back, take a look at it, make necessary adjustments, and then bring it back to the people. Yes, but in addition to the substantive act, there is going to be a package of regulations that moves along with it. Now, those regs, we're still in the process of getting those together, kind of tweaking and fine-tuning. And one of the important things about the regulations is we can't finalize that draft without the input of our stakeholders, because those regs are going to give the hard and fast details that all of our stakeholders need to be on board to ensure that business efficacy is there. We've properly considered certain administrative aspects, and we just provide a high level of efficiency through the implementation processes.
Well, we have 2 minutes left before the show ends, and I'll give you each a minute to say whatever you want to say about national health insurance. First of all, like you said, get that card.
Yes.
Yep.
Right.
I think for me, really, I want us to realize that this is a journey that we're starting, but we need to take that first step. We need to get to implementation actually starting. Will it look the way even we envisioned it would have looked when we first launched? No. But it does allow us as a people to have a process that we have input into, that we can change as we go along. We can make this the type of program that we want out of all of our systems, the way it can evolve with how we evolve, both economically, health-wise. We can make sure that this changes and becomes, to me, this could be the premier health system in the world, not just in our region, because we have learned from every other, process that has gone in, and having those other 90, 100 countries who are working on universal health coverage allows us to take those best practices and apply them right here in country.
Yeah.
Is there a website that people can, I know that you can't have the legislation on it yet, but is there a website yet that they can perhaps take a look at? Or
Yes.
I know there will be, but
Yes, there will be. There is a website that currently has information posted to it, and we're also working with our IT consultant on team to make sure that that legislation is able to be uploaded to the usual government portals or the government website, so that when persons can do an average Google search per se, and they're able to just type in NHI legislation, then they're able to go to a link and they're able to open that particular link and access the legislation. But once we get to the point where that legislation is released to the public, we will definitely ensure that the necessary information to direct persons to where they need to go is given to the public, so that they're able to access that piece of legislation.
and of course continue to stay tuned to the Broadcasting Corporation of the Bahamas, because as the information comes, we'll have it for you. Dr. DeLon Brennan, Damar Dillett, and of course my schoolmate Deborah Bastian. Wonderful for you all being here on the Reid Factor.
Yes.
Thank
Thank you.
We'll see you again. I'm Julian Reid.